Hello everyone, I'm Sattariya Pan. Today I would like to propose my intervention study which is automatic external defibrillator location system in our hospital cardiac arrest. Our hospital cardiac arrest is a leading cause of death among adults in US. Most of them is from cardiac etiology. This picture shows latest data about the cause of death in US. Heart disease is the most common cause of death now. Its adjusted death rate in 2011 was 173.7 in 100,000. Approximately 300,000 OHCA events occur each year in US, and 92% of them will die. Latest data from cardiac arrest recently to enhance survival or cash show only the 9.6% survival to discharge from hospital. It's what very low number. Even it was improved from 7.9%, which was percentage before that time. This slide shows the risk factor of OHCA, which is age, BMI, diastolic blood pressure, lipid profile, smoker status, coronary heart disease, ECG. As you notice, it is similar as the risk of coronary heart disease. Because coronary heart disease is common cause of OHCA, the data show the hazard ratio. There are little difference between men and women because sex is effect modifier in this topic. This slide shows about the watch factor proved to improve survival rate in OHCA. There are many studies working on this issue. These are just only examples of them. The first one is a high quality CPR. It means that you perform the chest compression adequately. You help patients. Data show increased compression fraction rate or increased time of chest compression, increased survival rate at just ratio 3.01. It means that how fast, how long, how often you chest compression will increase chance of survival rate to patient. Do not pay attention too much in mouth-to-mouth. Other studies show that just only the chest compression only do not do mouth-to-mouth can help people. Odds ratio is 2.8 and 3.4 when time from call EMS to first AED analysis below 10 and more than 10 minutes respectively. Early defibrillation is one factor can improve survival rate. And this factor is this in this study, pay attention. The graph shows every minute we delay defibrillation, it decreases chance of survival of patients. This meta-analysis of 3 studies which compare CPR alone with CPR and using automatic external defibrillator or AED for the early defibrillation, data shows CPR with AED in trained non-medical personnel can improve outcome. Number need to treat is 17 for the survival to hospital admission and 24 for survival to hospital discharge. This proves benefit of early defibrillation by AED in public. My intervention will pay attention in early defibrillation by AED. This graph encourages the hypothesis that early defibrillation will increase chance of survival in our hospital cardiac arrest patients. Data from CASH show the subgroup in witness collapse by bystander and get CPR and AED get 30.1% survival. It's worth more than 9.6% in overall. So this patient group will be a group I pay attention. The other study in Netherlands show how long you reduce time to first shock. You can save more money as shown in slides. Time to shock in 2-4-6 minutes can save more than 17,000, 14,000, and 12,000 euro respectively because you would decrease the ICU length of stay and so on. By the way, despite the potential improving survival rate in OHCA patients, data from CARE show only 3.7% of them were applied with AED by bystander. The challenge of AED usage are not only knowledge of layperson, but also many people don't realize exactly where it is when the OHCA occur. There was a study find out why in the questionnaire study. The first group have 506 response for the questionnaires. 64% know the AD is used for. Just only the 43% know about availability of public access defibrillator. The other group, which was 512 response from the questionnaire, 70, 47% able to identify AED, and just only about half know about the purpose of AED. There are no case study identify barrier in this issue. I propose this problem in my case control study proposal. Data of this slide show that there are some knowledge gap between the medical personnel and general population. So intervention study, I am trying to filling the gap by using AED location system, which is called AED link. The system will work in the emergency medical dispatcher system. When OHCA occurs and someone calls 911, dispatcher will send the medical team to help. However, the time is critical. Before ambulance arrival, dispatcher will give instruction for bystander to provide CPR and get AED. The problem is shown in the last slide. In their situation, people don't know where AED is, and AED location system will help the dispatcher know location of AED, and dispatcher can tell bystander to get the AED to help the patient. Even some areas in US already use this system. There are no studies to prove effective of this system. And Pennsylvania, where this study is planned in, has not used this system yet. I come up with a figure at this slide. P as a population in witness out of hospital cardiac arrest by bystander and shockable rhythm in Pennsylvania, US. I as an intervention is the AED location system provided by the emergency medical dispatcher. C as we compare with standard dispatcher CPR instruction. They give instruction how to perform chest compression and ask bystander to get the AED, but not use the AED location system. O as outcome, we evaluate effectiveness of study by looking at the percentage of bystander using AED as a primary outcome, time to first defibrillation, return of spontaneous circulation or ROS, survival to hospital admission and hospital discharge as a secondary outcome. And there, as I told you, there are no studies like this before. Primary objective, I look at the effective AED location system by the emergency medical dispatcher in the intervention group for the increasing percentage of bystander AED using compare the standard dispatcher CPR instruction or the control group. Secondary objective, I determine the secondary outcome between the intervention and control group for look at the time called EMS to first defibrillation, return of spontaneous circulation or ROS, survival to hospital admission, and survival to hospital discharge. This study is randomized controlled trial and conduct in community based. The study planned to involve community for collecting data for the place where AED is. Emergency medical dispatcher will use this system and collect data about time of EMS call and defibrillation by bystander with AED. Emergency medical service will provide medical intervention along their protocol and collect data. Hospital will involve this in this study because most of the outcome data will get from hospital. The detail of data collection will be discussed later. And as I told you, the study will conduct in Pennsylvania. Inclusion criteria in this study are the patient with out of hospital cardiac arrest who age 18 or older, witness arrest by bystander, and found shockable rhythm at first ECG analysis performed. AED give instruction for defibrillation at the first time, and EMS providers identify rhythm when they arrive. In case EMS provider arrive before the public AED use. Exclusion criteria is OHCA occur at place where AED is not available or far away more than 300 meters. Study design and method. First step, this study will send to the Institutional Review Board or IRB for the review about the ethics. Then we will establish AED registry in Pennsylvania for collecting data about the place and how long battery is used for the maintenance phase. Input the data in the AED location system and train emergency medical dispatcher to use it. Fifth step, RCT will start and measure the outcome until the complete all number of sample size. Last step is analysis data. The whole study will spend around 24 months. Look at the step 5 in detail. When the OHCA occurs, bystander call 911, then dispatcher know the place of OHCA. Some of OHCA will be ruled out from this study where the place don't have the AED or too far to get it in time. In this study defined at 300 meters, the rest of the OHCA will go to randomization in a block of 10 and put sequence in envelope. Dispatcher will open the envelope to assign the intervention group or control one. Intervention group dispatcher will use the AED location system. On the other hand, dispatcher will give only the standard CPR instruction in control group. When the EMS arrival, they provide medical intervention and ask medical history and ask contact information of bystander in case the data of bystander cannot correct in field. The investigator will call back to bystander in other day for asking information such as the experience of CPR, having a training before or not. EMS will send the patient who get the return of spontaneous circulation or ROS to hospital. Hospital will collect data about the outcome of this patient. The whole data will be collected in a web base for everyone who involved this project can access from anywhere. For conclusion about the outcome measurement, data from EMD, they will collect the percentage of bystander AD using the time EMS call to first defibrillation. The data from the EMS provider, they will collect time EMS call to first defibrillation in case the first defibrillation is given by the EMS provider. ROS, P-hospital interventions like an airway, number of shock drugs as a confounding factor. The demographic data of the patients, CPR and AD experience of bystander and contact information in case they don't have the time to do this. Data from the hospital, they will collect the survival to hospital admission, survival to hospital discharge. Hospital intervention such as length of ICU stay, cardiac catheterization, therapeutic hypothermia as a confounding factor also. This is how I calculate the sample size for this study. As I told you, there was no study about this topic before. I used data from CARES which showed 49.2% of subgroup witness arrest by the bystander and got a shock embolism had some intervention such as the CPR or the AED using. There is no data, only the AED using. Therefore, I use this number for calculating sample size. I assume this intervention will improve the AED using to the 80%. And I use the type 1 error at the two sides at 5% and power is at 90%. So sample size is 51 OHCA patients in each group. And overall it's 102 patients. Move to the anticipated outcome. This table shows the your suspected demographic data that I will correct. And I compare intervention and control group. They are supposed to be not significantly different because they are separated by the randomization. Some data will be confounding factor or the effective modifier for the outcome. Data consists of sex, age, cost of OHCA, bystander CPR, experience of bystander, number of defibrillation. The data will compare median time from call 911 to the emergency response, such as ambulance arrival, such transportation, the time arrival to the hospital, or ROS. The table shows the continued part of the demographic data. The data is medical history of the OHCA patient and hospital intervention. And this table shows the primary and secondary outcome I correct, which are bystander AD using median time call 911 to first shock. Number of percentage of patients got the first shock within the 4 minutes. ROS, survival up to hospital admission and discharge. I compare two groups by the odds ratio. Time call 911 to first shock within 4 minutes is used for the correct data in this study because it's a recommend from the American Heart Association. So AD or the first shock of defibrillation should be provided in 4 minutes. The strength of this study are the first is this a randomized control trial, and this first study about the AED location system. The intervention I propose is low-cost intervention. I use the existing technology. We have it already and free. However, it needs human resource for correct data. Uh, I high impact outcome because OHCA is a high incident and high cost disease. However, there are some limitations which are it's hard to collect the time data because a clock in a dispatcher unit might not be the same as one of EMS unit. There is a problem of the validation data such as the time of defibrillation. I try to collect confounding factor as much as I can, but it will be an unexpected confounding factor. The last one, the sample size. There are no data for the calculating provided. Therefore, I assume the estimation of previous data as I shown in that slide. And these are my reference. And thank you for your attention.